going to say, do I get slides? Oh, my name. Oh, there you go. That's a good start. Oh, it's magic. Good. Morning, everybody. It's good to be here. As Sean said, my name is Pat Field and I'm doing a PhD. I'll go through some of that journey and also talk about cardiac rehabilitation at the same time. So firstly, I'd like to acknowledge the Aboriginal and Torres Strait Islander peoples as first inhabitants of this country and pay my respects to the traditional owners and elders past and present of the Kalkadoon people. And this is my first trip to Mount Isa, and I walked up to the lookout this morning and didn't quite see sunrise because I had to come back to have breakfast. It was wonderful. Yeah, it's sort of inspiring, and I love the desert, but the contrast of the mine is lovely. Anyway, I thought I'd give you a little bit of background about me because I think it helps to sort of where I am at now. I'm a nurse, and in the 70s and 80s I worked in hospitals, and then I went to work in Central Australia. And during that time I met wonderful people, such as Pat Anderson, who's sitting down here. We reacquainted ourselves in the lift this morning. Lenore Geyer, who's in Townsville, and also Sabina. So it's sort of like coming home, although it's different country. And during that time, I realised it was a bit of a shock that health wasn't about hospitals. Health's about everything else but hospitals, really. And so I changed direction there and really went down the public health track. In the late 90s, I went to work for the Heart Foundation and continued with the rural, remote and Aboriginal and Torres Strait Islander focus. And during that time, I travelled a lot. And one day I was sitting down with a group of CWA women, and they were telling me about when usually their men were discharged from hospital and having been into a major metropolitan hospital, came home and they really had no idea what they should be doing from there on. And they tell stories like either they couldn't get them out of the rocker recliner, or they'd be back on the back of the tractor sort of ploughing and whatever. There wasn't much middle ground. I then went away and worked in the Pacific for some years, came back and found that things hadn't changed. And so I'm here now, and through the PhD program, I'm aiming to try and make a difference. So I'll give you a little bit of background. I sort of thought integrative review, it's really quite boring, but necessary, I think. So the background of heart disease, it still remains to be the biggest killer in Australia. The deaths, this is in 2013, was nearly 20,000 from coronary heart disease alone. And but the men are slightly higher than women. It's only 11% difference, so it's not huge, but there is a difference. And 1 in 5 people have heart disease in Australia, and it gets worse as people get older, which you would expect. And the costs obviously go up in age groups. I thought this cost slide was quite interesting because, having just said that there's more men than women, that it's only an 11% difference, but look at the difference in what we spend on men compared with what we spend on women. It's never been explored, but I thought it was a very interesting slide. Cardiac rehabilitation, why do we worry about it? It's very evidence-based best practice, been around for a long time. Not much of this is new, but it's sort of stuck at the moment, and I think we need to move things forward and probably do things a little bit differently. It really needs a lifelong commitment. It's not just a 6-week program, which is what people tend to think a bit about being. The 6-week program can be the catalyst to start you, hopefully, on a lifelong journey of improving health. There are other ways, home-based, usually with telephone support. In Queensland, there's the COACH program, which is Coaching on Achieving Cardiovascular Health, which is a Brisbane-based program, but it does attempt to provide telephone support, and it works with the GPs and also with the clients, and monitors people's progress and gives them support. Still only reaching quite a small percentage of people. And then there are some apps out there, but I'm a firm believer, actually, you've got to have people involved somewhere along the line. for most people. So participation rates are still very low. The international recommended rate is 65%, but in Australia we're generally only reaching 30 to 45%. And we haven't got firm data in Queensland, but it's coming. They're working on it, and they hope to have the first figures out this month. So, why do we bother? Because you get huge benefits. 70% reduction in repeat heart attacks, and of course that has big cost implications of people reducing the rate of readmissions to hospital. 47% reduction in mortality after 2 years, and significant improvement in quality of life, which results in savings. If we could get the referral rates and attendance up to 65%, it's a huge ask, mind you. Especially, we're going to start focusing more on rural, remote areas in a minute. Savings of nearly 87 million a year. So, governments should be interested because they like to save money, but they have to spend a bit first, you see. That's always the dilemma, isn't it? So we know, what do we already know? Sparse services, we know that, particularly in these rural and remote areas of northern Queensland. Staff turnover is high. A lot of these things have already come up. You'll get a new inexperienced health professional. Takes them a while to find their feet, get up to speed. That tends to put a bit of stress on the rest of the team, and that becomes then, you know, an escalating factor. And I don't know what the turnover rates are in Queensland, but I know that they are likely to be very high. People have poorer health status. So the demands on staff and services is also high. It's probably worse than it looks, because than the data actually shows, because there is evidence that if people have got the resources to move to urban centres as they get older, they often do. And so quite some of the sicker people actually leave. And there's a continuing gap, of course, between First Peoples and other populations, and all of this is very well known. So looking at Queensland, northern Queensland, which is the area of focus for me, the furthest centre, cardiac rehabilitation centre in the north, is in Mossman. So there's an awful lot of northern Queensland and western Queensland that doesn't have any centre base. So, you know, let's not focus too much on centre-based care, because it's unlikely to happen. And in the west, there's a program I know in Mount Isa, and I don't know much about it, but I know it's here, and I'm sure it's very good. And Hughenden is trying to do something. They've done something in the past, and they're struggling to try and get something. So there's very little in the way of centre-based care. This I thought was interesting, and I threw this in recently when I was thinking about socio-economic factors. And the dark red is the most disadvantaged socio-economically. Okay, so that sort of speaks for itself. The blue areas is one. Just sorry, I'm not having much success with the pointer here. Oh, there we go. Is Cairns, and these, you can't see it very well, but there's dark blue areas up here, or the pointer's coming up blue, and Cairns, and Townsville is the same. They're the higher socio-economic areas as far as advantage. Okay, so it's very clustered on the coast. The orange is sort of in the middle, and also the yellow is slightly higher, but obviously a very overall disadvantaged region. This is some data I got recently. We just recently got a big database over the last 5 years of heart disease hospital admissions, which we're planning to do a lot of work with. This is part of my research. We just put together a couple of slides, which Richard Franklin, my advisor, said, I have to say that the data hasn't been cleaned or checked yet. Okay, just in case. But they're interesting, because if you look at the 40 to 50 age group, here we go, here, Now, this is females. Now, the population, the Indigenous population of Queensland, whole of Queensland, is about 4%. But you see that the hospital admissions is actually up to about 16%. And that's a guess because I'm just looking between the lines here. And it reduces as people get older, and then of course it's way down here, down to about the 4% here, but that's probably because life expectancy of First Peoples is not terribly high. So we lose them along the way. So clearly very overrepresented in these age groups, the younger age groups. Now in this one, men are less than women. So, which is, a reverse from the rest of the population. 2 minutes. Okay, I've chatted too much. The literature review, I don't really need to tell you about that. We're looking at barriers, enablers and pathways. We had inclusion and exclusion criteria to sort of narrow our papers down. We ended up with 16 papers. And what were our findings? We saw low levels of referral. This is from hospitals. We found little eligibility criteria, so there's no evidence as to what the decision is based on as to why people are referred or why they're not referred, so we need to look at that. And post-discharge and follow-up support was quite often weak. Geographic access is obviously a problem, travel costs, and this is not new to any of you people. Inflexible programs. Somebody goes back to work, there's only a program available Monday to Friday, 8 to 4. Professional roles, often inadequate staff, we talked about that. Doctors sometimes perceive themselves as a one-stop shop, and you don't need to go to cardiac rehabilitation, you just need to come see me. Quite a few articles actually mentioned that, which was interesting. People didn't really see that it was necessary, it was benefit. They were fixed, and you would have heard people say that. I've been into hospital, had my bypass, I'm fixed. Or they'd say things like, no, they were either too well, too sick, or too old to go. So it didn't really matter which way you looked, they sort of had it covered. And it's expensive. And that's a barrier. So conclusions, the services are inflexible, they lack a systematic policy-driven approach, there's a need for greater flexibility and increased availability of alternate programs, and I think they need eligibility criteria. It's known that it works and too few people access it. So where to from here? We need to close the gap and we need to get more people going. And how are we going to do that? This is really the journey I'm embarking on now, and we want to investigate what happens when people go to hospital, what happens to them in hospital, what information they're given, and what they know about their post-discharge care. So the patient-centered care, the client is informed and they can take charge. And that the right paperwork gets done, so the health professional in a rural area, they know that this person's been into hospital, what's happened to them, and what is their follow-up care. There's still a gap there. And then I want to go out to communities. I'm looking at Hughenden, Cooktown, Hopevale and Wujal and go and actually interview people and talk to them about their experience once they leave hospital. This is people who've been treated for heart disease. And we'd be looking at alternate models, which we've really already talked about. So that's it. This is my overall topic, and oh yes, I should just do the acknowledgements. I've got a wonderful team with me, Professor Richard Franklin, Ruth Barker and Ian Ring, with Peter Leggett's support, and I've also been working with the Aboriginal and Torres Strait Islander Leadership Advisory Council in Townsville, and also not so much except a little bit in Cairns as well. So it's been great. Thank you very much. Cheers.